Hello everyone. Today I welcome you all on behalf of the Department of Oral Pathology and Oral Microbiology. Myself, Dr. Dineja. We are going to see about the topic lateral periodontal cyst and botrite odontogenic cyst. First, let's see the definition. A cyst is said to be as a pathological cavity having fluid, semi-fluid or gaseous content which is not created by the accumulation of pus. It is frequently but not always lined by the epithelium. Lateral periodontal cyst. Lateral periodontal cyst is a developmental odontogenic cyst and it occupies the lateral periodontal position. The term lateral periodontal cyst have various etiology, all these cysts developing in the anatomical region of the lateral periodontium. There are three possibilities for the origin of lateral periodontal cyst. The first one is the lateral periodontal cyst can arise from the reduced enamel epithelium. So these are the cells which usually degenerate as the tooth is progressively revealed as it erupts in the oral cavity. Then the second possibility is that the lateral periodontal cyst can also arise from the remnants of dental lamina, which is nothing but the discrete clusters of residual cells of hers. Then the third possibility is that it can also arise from the cell rest of malices, that is a group of cells which is present in the periodontal ligament. There is also a hypothetical pathogenesis, which shows that initially inside the bone the follicle expands asymmetrically with the reference to the crown. Then later on, during the process of tooth eruption, a certain part of the follicle is alone left behind inside the bone. This remaining follicle represents the site of eccentric follicular expansion. Then finally, the encapsulated epithelial remnants lie intraosseously behind the root of the fully erupted teeth. Now let's see the clinical features. Usually the lateral periodontal cyst is asymptomatic and it usually detected by the age of 5th to 7th decade. The most common site of the occurrence is in the mandibular region between the premolar, canine and incisor region, and that too between the roots of the vital teeth. Radiologically, it will show a small round to oval well circumscribed radiolucency which measures around 2.5 mm to 15 mm in size. Let's see about the histological features. The lateral periodontal cyst. In this cyst, the cystic lumen is lined by the non-keratinized squamous or cuboidal epithelium which resembling the reduced enamel epithelium. The typical feature of lateral periodontal cyst is the focal hyperplasia of basal cells. These plaques may extend within the connective tissue or intraluminally. Epithelium may show intracellular fluid accumulation at places and glycogen-rich clear cells is also seen. Now let's see about the differential diagnosis. Lateral periodontal cyst has to be differentially diagnosed from the gingival cyst. Usually this lateral periodontal cyst seems to be the early detachment of reduced enamel epithelium during the process of tooth eruption, which is giving rise to the periodontal cyst, while the gingival cyst will arise from the post-functional epithelium after the eruption of the tooth. Then the lateral periodontal cyst is developing inside the alveolar bone, while the gingival cyst is located outside the alveolar process. This makes to differentiate between the lateral periodontal cyst and gingival cyst. Now let's see about the botrite odontogenic cyst. The multilocular variant of lateral periodontal cyst is called as botrite cyst. The botrite cyst resembles the cluster of grapes, and it is believed to arise from the fusion of multiple lateral periodontal cysts which is developing in the proximity to each other. Lateral periodontal cyst, if left untreated, may fuse to form a multicystic lesion which is referred to as botrite variant. And group of converging cellular debris of serous incorporated into the periodontal tissue or from the reduced enamel epithelium of the follicle which expands to occupy a space in the periodontal ligament during the eruptive phase can give rise to the botrite odontogenic cyst. Now let's see the development of botrite odontogenic cyst. Initially there will be the thin epithelial lining which is resembling the reduced enamel epithelium. So followed by it there will be the focal swelling, that is nothing but the proliferation of the basal cells. Then there will be the continuous proliferation of basal cells where the superficial cells will lose its contact with the basal layer and swells up by the accumulation of intercellular fluid. Then there will be the proliferation which creates a first plaque which is lateral to the initial plaque. This plaque detaches partially and protrudes into the cystic lumen, which slowly grows. Then the plaque can cause convulsions as like the daughter cells, which give rise to the botrite odontogenic cyst. Let's see about the clinical features. Clinically, the botryodontogenic cyst will have a swelling along with the pain and paresthesia. Radiologically, we can able to identify the largest cyst, which is ranging from 4 mm to 45 mm in size, and it can be either unilocular or multilocular. On excised lesion, we can also clearly appreciate a multicystic variant. Histologically also, we can able to see multicystic or unicystic lining, which shows the thin connective tissue septae lined by thin stratified non-keratinizing epithelium. As like in the lateral periodontal cyst, the foci of plaque-like thickening is also a classical histological feature in botryodontogenic cyst. Let's see about the treatment. Conservative enucleation of the cyst is most common treatment for lateral periodontal cyst as well as for the botryodontogenic cyst.